Okay, I would like to introduce Dr. Elisa Tong from UC Davis, who's going to be talking about California Smokers Helpline and TRDRP-Funded tools for smoking cessation. Thank you for coming down, Elisa. I look forward to your talk.
Great, thank you. And thanks everyone for having me. I think Smoking Cessation Day is a great idea, and in fact, I think this could go viral. I don't know of any other county that does this, so I am looking forward that we're going to keep spreading this around. So I'm a general medicine doc, and I also do tobacco control policy and cessation research. And you're probably wondering, what is a UC Davis person from Sacramento doing down here? But I kind of fell into working with the quit line a lot, and also I do have family here, as Norma knows. So LA is dear to my heart, and I am very passionate about tobacco control. So, but I will share more in a little bit. I just want to acknowledge some of our partners on all of this. So, you know, we were talking with the helpline, and then I think with one of the LA docs, and then they said, hey, we have this, you know, why don't you talk to Dr. Hal Yee about some of this, about connecting to the helpline more, like what we were doing at UC as well, and this kind of spiraled into this dropping the helpline into eConsult. Which I'll get into a little bit more. I'll share some of our pilot results. So we had a 2-year pilot to get this live, and thanks to TRDRP, you know, we're one of the 3 projects that are now funded for 3 years to work on implementation for cessation. So let me see if I can advance the slide.
Push the next button.
Next button.
Right.
Okay,
and
thank you.
The rest of them just don't work.
Oh, okay. So I don't think I need to go too much into background on the helpline because we've had so many wonderful speakers already about this. And again, it's a 2-part problem. These are slides adapted from UCSF's curriculum for med students called RX for Change, and it started with pharmacy students, and then they expanded it to other health professions as well. But this is one way I bucket it for myself. It's the physiologic part with the nicotine addiction, and I started off my research career looking at tobacco industry documents and realizing how they engineered these devices to be so addictive, basically free-base nicotine, and now you've got all these new products. So there's that component, and then there's also the behavioral part where I do a very simplified explanation to patients where I say it's pretty much hardwiring that addiction into what your daily routine is. And I like how the helpline, we came up with this, if you don't succeed at first, quit again. What I say to patients, I think you said, how can we reframe the 8 to 12 tries before you quit for good? What I like to tell folks is, you know, when you first started to walk as a baby, I don't think most of us walked the very first time we tried. You know, it's something that you have to try again. So I try to frame it that way. The 5 A's have been mentioned as part of that evidence-based framework for helping someone who uses tobacco. And also I'd like to throw in for someone who's exposed to tobacco as well, because we know that there is no safe level of smoke exposure, which the Surgeon General has come out with that statement. So ask, advise, assess, assist, arrange. But, you know, we did a study before, and this is with Dr. Steve Schroeder, who's over at UCSF. And he had done this big nationwide survey of all the U.S. health professionals, and lo and behold, we found not everyone is saying that they're doing all 5 A's. And primary care docs probably said they do it the most, and recognize this is the providers saying what they do, not what, you know, someone actually looking at to see did they really do that or did they document it. And the barriers to the 5 A's, a lot of it was about competing priorities, and I think a lot of folks in the room probably appreciate that. Believing counseling wasn't an appropriate service, being uncomfortable asking if someone smoked or talking about it, not being their primary care doc, being a smoker themselves. So there are a lot of barriers that health professionals have, even the ones who are on the front line of seeing smokers. So we also had psychiatrists in this survey, emergency medicine docs who are front line for a lot of safety net. And then there are other health professionals in this survey too, for nurses, pharmacists, and dentists. But we did know that facilitators of doing these 5As was if you believed it was an important responsibility, if you had training, you were aware of the public health service guidelines, which everyone has been showing the cover for. So you being here in this room already is a huge start for all of our patients. So recognizing that the 5As wasn't always possible for everyone at every time, Dr. Schroeder and others, started promoting how about the quit line, and Ask, Advise, Refer became another model, and refer to someone. So this is coming from, especially from a primary care perspective, referring to a resource like the quit lines or referring to community resources that can help you through the process even more. And I think a lot has been said about the helpline. It's been around for over 25 years. I still find it's one of the best kept secrets amongst providers, or even patients. They're not quite sure what the 1-800 number is, and I like to say, maybe it's because I'm at a UC, but I like to tell them that it's at UC San Diego, so it's not somewhere, in virtual nowhere land, and that I like to say that also that it doubles the chances of long-term quitting. And if you want to look up their New England Journal of Medicine trial, it's back from 2002. And so the host of services, I think it's already been described about what they offer, but a lot of free resources, and it's open to everyone. And I usually go through with students or trainees about what happens when you call, but I think Gary and others have already talked about this, that it's an intake call. You don't have to be a smoker. Actually, friends and family also call. So our pediatricians are also referring to the helpline for, say, a parent. And then what happens is you have that intake, they'll get your demographics, and then if you're ready to have that counseling call right then and there, they'll do it. Otherwise, they'll schedule it for another time. And sometimes when I try to promote this to patients or educate patients about this service, I will also just say, they'll just help you get started. If you're not ready to talk, they'll send you this wonderful free workbook to start working through and doing it yourself, because I have a lot of folks who say, I just want to do it myself. I don't need to talk to someone. But those are ways that I try to also help people understand what are next steps. And I think, as Gary mentioned, there's the website text program and app, and go ahead and try it yourself. I enrolled in the text program just to see what happens, and I have no problem telling Gary and others, like, hey, this thing is, is this working right? It looks, maybe my update didn't, quite work out, but I think it's also good to just try it and see what happens, so that when you talk to your patients, you'll also see what is available or what kind of messages come through, and it's great. Just so you know, also, I think Gary may have mentioned this, but there's also a county cessation program list on there, and so maybe this is also another place we need to put in for the LADHS DMH service, and this is updated annually. So, for example, I had a patient in Sacramento who said, I don't want to talk to anybody, I don't want to use meds, I just want acupuncture. I know, and I'm like, look, let's just get you started. So, lo and behold, there was an acupuncture group on our Sac County cessation list. So something where I can just also have other resources for folks. All right, so let me just switch gears to the meat of this, because the eConsult pilot that we did, we haven't had a chance yet to really disseminate out to folks what has been going on, and we know that we can expand and build upon what was started in this 2-year pilot. And just all of you in the room know about how large LA County is. So, and when I go outside of California, everyone says, oh, isn't it wonderful you guys have smoke-free policies. There's no problem with smoking in California, but all of you in the room know, that smoking is still a problem, especially with there are disparities, especially with low socioeconomic populations. So I like to tell folks, there's still over 3 million smokers in California, and we have a very diverse population. And I think we also had one of the helpline PI, Dr. Ju, he did a study in the California Health Interview Survey that showed, because of this whole Medicaid shift, actually amongst California smokers, 40% of them are covered by Medi-Cal. So that is a huge demographic. I mean, it's great. It's probably some people getting recategorized from uninsured and got coverage, but this is a wake-up call for all of us to say this is really a population we need to work on together. So part of this whole eConsult process, I was just reflecting with Gary, because we've been, at UC, we've also been connecting electronically with the helpline. But I think the thing that was unique to LA County was that there is this eConsult system, which is like a web portal, but it's not just available to DHS, DMH. It's also available to the 200+ community partner clinics that serve the MyHealth LA patients. So it took a while for me, not being a user on the LA DHS end, to understand the complexities of this, but I think that's why the eConsult portal was used. So here's just a screenshot of what it looks like. So what it's meant for originally is for a primary care doc to say, hey, I have this patient, maybe needs to be seen, not sure, let me just, do a secure communication with a specialist, see if they need to set up an appointment. So this is the portal that funnels everybody through that. So it's a little bit more MD oriented, but at the same time, it was a portal where we could say, well, why don't we drop in the helpline as a specialist in there? And so that was what the pilot did, because it was an existing portal that everyone had to use in order to get a specialist appointment. And this was also shown to help to reduce access barriers, because I think before this, you would just take months before you got in to see a specialist, and by then, maybe your problem got worse. So this has helped to address access barriers, but I think we just leveraged that portal and just dropped the helpline in. So that happened in 2016, and to date, which is great, we've had over 800 eConsult referrals to the helpline. And what happens when you electronically refer to the helpline? And now it's called not just AskAdviseRefer, but because we all need to use electronic health records, someone actually came up with AskAdviseConnect. So connect meaning that it's not just telling someone, call this 1-800 number, go get help for yourself. It's the provider in the room saying, I'm going to have someone call you, and I'm submitting the order, and they're going to call you in the next couple days. And so then hopefully the number is right, but the patient will also get the call from the helpline saying, hi, or the California Smokers Helpline. So this is just us at UC Davis. We got the first one set up, I think 2013, and these arrows just show that this is just the flow of the order. It just goes to the helpline, and then actually in our EMR, we get individual level data back about the help from what the helpline did. So they're just some canned messages saying, patient did the intake, patient received counseling, or on the other hand, patient refused our services. So there's just some things that are standard that are programmed into their system that they can push back to us. It's not a whole full detailed note of the whole conversation. It's just sort of to let us know service outcomes. So across the 5 UCs, we had a project where we shared the electronic build and some of our other modifications. So we actually altogether have had over 10,000 e-referrals, and which may sound good, but then of course there's more to the story, and I'll show you some of this as exemplified by the eConsult data. So what happened with the implementation? So it was a pilot. So, so what we wanted to show was that we could get this done. And so we didn't want to go do a huge rollout. I think what happened was there was some notification to the docs who use eConsult that the service was available, that is on the landing page when you go to the eConsult portal. And once we did that, that's when we saw referrals take off. And so, and then subsequently things dipped down, and then they would tell the primary care work groups. Dr. Tyler Cito, who works over at the Long Beach Clinic, has been part of this as well. And then also letting the MyHealth community partner clinics know about this too. So there's been some notifications of folks, but we haven't done the deeper dive to explain to folks what the service does or, you know, what happens, things like what you're getting today. So this is the other part of the story about just that number. So it's nice to feel like there's a Fitbit number behind this, that, hey, we're helping all these many smokers. But the reality of it is, even, you know, the smokers, for whatever reason, they have varying outcomes. So amongst all the 800 plus referrals that we've had so far from eConsult, about half of them pick up, which is the reached part that you see in that second tier. And the first time I presented this to the 5 UC folks, they said, this isn't good. Are you telling me that you referred a patient and only half of them picked up? You know, that's not good care. But I think we've been seeing this across a lot of different e-referrals, and not just California, but nationwide, and everyone's saying, did someone say yes to a referral and then didn't pick up for whatever reason? And so I think for a lot of docs, that was sort of an ego check, like, yeah, they said yes to you, but really they said they meant no. You know, maybe they were just trying to please you at the time. So I think it's still sort of a puzzle for folks, like, why are only half of the folks referred picking up? And then amongst the folks who do pick up, a good proportion of them do go through with the counseling, or at least they agree to counseling, and then complete the first counseling call. And you'll see that there's in that third row, there's a number of folks who just want materials only, that nice workbook that they will send for free. And some folks just never get around to completing the rest of it. They'll just do the 8-minute intake. So this is the realities behind that e-referral order number. I just wanted to show you that it's a little bit messier and complicated than just a number of referrals. And so that 10,000 e-referral order number across the UCs is the same thing. We see 40 to 50% have been reached.
Before you move on from the slide, is it okay to ask a question?
Yeah, sure.
Can you go back one slide? The 102 that refused, do you have any sense of why?
Maybe Gary would have a better answer, but
you know, one thing that you mentioned earlier was that they agreed to the office, but when it came down to actually talking,
Got it.
yeah.
I don't know what percentage is that.
Yeah.
Of the 213, do you have any idea how many of those actually quit and called?
So right now, the helpline does do a 5% quality check on all callers, but we did not have the resources to call back all these folks. But we will in this next phase.
Can you just like, if I call, for example, my English is limited, and I call the language only English, Korean, Chinese, and Vietnamese, so what I'm going to get from that service, and no patches provided, so I'm calling for what? That was my question.
What I tell patients is if I hear two parts to that question is, so first of all, I'll tell patients, I'm referring you to someone to help you work through an action plan to get started on how to stop smoking because of the behavior change part. But what I also hear is what happens maybe for someone who has other needs. So language, for example, I keep getting asked by the LA Care Health Educator folks, where's the Armenian language line?
Mainly men things to smoke, so they feel that I'm a man, I have to smoke.
Right.
So that's a big population there. They ask, I'm Armenian, that's why I know. They just give me what to offer, and I was giving them. And they're coming to me, just like, why did you not refer that to me? And I was like, I didn't know, I'm sorry. That's the reason I came. I want to hear what's going on, that I have an answer for it.
Sure, and I'll touch on the Medi-Cal Incentives to Quit Smoking project, what we're hoping to do moving forward with that. But I think in terms of other languages, because Russian comes up a lot too, or other Middle Eastern countries, I do believe the protocol is they may call an AT&T translator, which is not great, but preferably a family or friend. So this is one of those access issues, I think that's always ongoing, but it's also on, I have a long wish list, and it's always a matter of trying to find the priorities and resources for addressing these. Yeah.
And do they call at certain times? Because I was thinking about that half of the people.
Okay.
At certain times people maybe are working or.
Right, so the callback, when are they calling back? And that's another potential Gary question, but I know if they'll just say, you know, this is a voicemail, please call us back. But they're open at evening hours too and on the weekends. So, and that has been one thing we've been wondering about, is it just a scheduling issue? Because we know for, you know, on the clinical side, no-show appointments are a huge problem too, and how do we try to counter that? Okay, any other questions? We can come back to some of these other topics as we go along. I just wanted to share the clinic level data, just so you know, you get a sense of where that number comes from. And you know, I broke it out in terms of the way that it's reported out on the eConsult thing. So even this LAC-USC part, you know, I know other clinics are kind of fall under that LAC-USC bucket as well. But just wanted to give you an idea that, you know, there were orders from the beginning from across all the clinics. And then the referral numbers, this is just total counts. It's not adjusted for how many smokers are in the clinic. But just want to give you a sense of who's ordering across. And I like Dr. Van Frank's idea that maybe we should celebrate some of these folks for actually going to the trouble of, you know, talking to smokers, saying we're going to get you some help. And so maybe this is something we should be celebrating. Maybe we should start awarding this at Smoking Cessation Day next year. Here's some of the smaller health centers, and obviously we could probably do more outreach and education to these folks as well, maybe especially for Antelope Valley. And then DMH, there were a few orders from there, and also, interestingly, we were surprised to see from the detention facility, which I believe LADHS also has one of the quality improvement projects is to work with the folks who were recently incarcerated. So, you know, also the community partner clinics. Just want to shout out to Queen's Care Family Clinics, who just blew everyone out of the water. And Cindy and I were reflecting on this, like why, you know, why are they just going gangbusters? And I think I've looked at the data, and I think there were 2 docs who really were doing a lot of the referrals. That at the same time, I think they've also worked with the county also, or the public health folks on increasing more referrals to the helpline already. So they've already been primed in other ways to do this. So that's not the whole story. You know, don't want you guys to have the take-home point being, well, that clinic did better than this clinic, because in reality, these eConsult referrals are just a small fraction of what's actually going on. This is just the monthly snapshot of the calls from LA County to the helpline, and the red tip, it's not meant to look like a cigarette or e-cigarette. The eConsult referrals are just a small fraction of the calls that are already coming in, because LA County, you guys have had cessation as a priority with the public health folks for years, and you guys are already, you know, way ahead of what a lot of other counties are already doing, besides being, you know, the largest.
Out of curiosity,
What was happening in April?
Oh, yes. So that was when the $2 tobacco tax happened. So we know there are certain things that trigger a lot of people, like Gary said, you know, and just like January is a month that people call the helpline. Yeah, that's that data point. I just want to say, in the larger context of what's going on, I don't know how many of you know about PRIME, but it's this quality improvement program that all the safety net public hospitals are participating in right now. And so this is just a snapshot of California, all the California hospitals. The blue dots are the big, large hospital clinic systems like LADHS or the 5 UCs, and the orange are the smaller hospitals, the district municipal hospitals, and the counties that they cover that are reporting on tobacco quality metrics. So finally, it's becoming not just you should do this, but you have to do this. And someone's measuring it and holding us accountable for it. And eventually, this is how we're going to be getting paid, is are we providing, I believe the term is value-based care. But this is just one start of about how are we assessing. And so this quality metric you might hear for right now reflects the clinic patients seen in the past couple years, and then the number of smokers that were counseled, and addition to the non-smokers. So I have a project team that's also, we're starting a statewide learning collaborative to help all these hospitals learn from each other and share how we should be doing a better job with this. And I just want to take the opportunity to share, I think Cindy Sangmaeda had shown this maybe in her slide, but just some of the breakdown of what is being reported to public, and this is, to the State Department in Sacramento that they're reporting this to. So how many people are being counted in the LADHS world for being in the primary care world, so over 100,000 folks in the denominator. Out of all of these folks that were screened, over 16,000 were smokers, and intervention could be anything from brief advice to medications to referrals, whatever is documented. And the number of smokers counseled has significantly improved from 21% in year 1 to almost 3/4 in year 2. So, things are moving behind the scenes. But at the same time, we also know that the eConsult referral numbers are only a small fraction of what's going on. So we know that there could also be room for improvement for that as well. So let me just switch from the pilot results to what we're looking forward to over the next 3 years. So this is just an overview of that workflow about what happens with eConsult. You have a tobacco user who shows up to the doctor at LADHS. Hopefully, the eConsult gets used so that then the smoker can get a call from the helpline, and that's sort of the overarching structure. And then we're saying, how can we improve on it? And the planning award, we just kind of went live with a technological fix that we know some people are already starting to use. So aim 1 is to look at this weird patient contact rate phenomenon of 50% of people picking up. And we know there are multiple reasons why people don't pick up, and I think some of the things were already talked about. And I was just curious, how many of these are bad numbers? And so one thing we've already done is just look back at the no contact folks from the referrals, and it's been about 7%, which I was like, is that, I had no frame of reference for what was good or not. So it was even just helpful just to get a number. And so one thing that we're still waiting to program is feedback to the provider saying, invalid number, please resubmit with updated information. I've had personal experience where the caregiver came in with the patient and said, I got a call from the helpline. I told them to go away. Why are they calling me? And I realized, okay, well, the patient was a smoker, and the thing that got pushed over was your information as the contact because you're the person to help. So sometimes those sort of things happen in the real world. At the same time, we know there's probably other buckets like scheduling and whatnot, besides someone just not being that interested and just trying to say yes to the doc. So this is something we're looking more into. Would appreciate if you have ideas also. Would love to hear what your experiences are. Aim 2, facilitating the workflow and submitting an eConsult to the helpline. And this is something we're currently working on and discussing, and hoping also with the DPH team with Cindy Sangmaeda that we can go out more and help educate about this availability of the service and the helpline. So, these are just a couple tips of what, for example, a primary care doc can say to a patient, or, for someone also asking about tobacco use. One way we're trying to help standardize this is not just say, are you a smoker, because there's a whole lot of identity issues in that. But one way to try to encompass everything is, have you used any tobacco products in the past month, including electronic devices? We haven't even talked about flash drive products like Juul, but, you know, people, they don't even consider that vaping. You know, they consider that juuling. You know, there's a whole lot of things that we're trying to capture when we ask this one question, a very busy clinic. And then I also like to emphasize, you know, if someone isn't smoking, you know, are you regularly exposed to smoke at, or, for example, at the home? And that would be a passive smoker. You know, then you can briefly advise and, you know, advise a patient. And one thing that you might say is the best thing you can do for your health is to quit, but of course, personalize it and see where the person is at. And then just to have some script of, you know, for the doc, you know, I'm just going to have the California Smokers Helpline call you in a couple days, just sort of set them up for that phone call so that they don't just ignore it, because we're all getting robocalls from who knows where these days, but something where they're sort of alerted that someone's going to give you a call and help you get started to stop smoking. And so for right now, look for this 1-800 number that's going to show up on your phone, because I know I just ignore a lot of the phone calls that come through. One thing we've been toying with is, well, what happens if we put I don't know, you know, is it a 323 area code? You know, what happens if we make it look like LA, but at the same time, we know there's a lot of spoofing issues going on with a lot of the robocall stuff. Just to let you know that we also, from our UC Quits project, have some brief provider training webinars. If you want to go tell other folks, we tried to make this brief for 15 to 30 minutes because we know not a lot of folks have a lot of time, but just want to let you know that this is out there. And we're going to renew the free CME hopefully in the next few months. So it'll be on our CME California website. Okay, and finally, because I know the medication part was a big interest, this is probably one of those grand challenge things that we want to figure out. So you refer to the helpline for counseling services. How do we integrate medication into this? Because we know medication also helps double your chances of quitting. So, you know, there's different logistical things that we need to try to figure out. One thought was, you know, that California pharmacists can be part of a team-based approach. And pharmacists can now furnish nicotine. And for example, they can also give combination therapy, so nicotine patch and a lozenge or gum. This is not important for the details, but just want to let you know that there is more information about how pharmacists, they just need to get a 2-hour education course completed and just say that they're going to track the patients over time. It's very easy to sign up and get accredited for it. Whether or not they get reimbursed, we're still talking to the UCSF pharmacy folks who are behind a lot of this about when that's actually going to happen. But this is a wonderful resource, and if there's pharmacists in your clinic who are interested in doing this, they're amazing partners. And then finally, the 2 pilots that we're also kind of saying we will be exploring during this is one, data sharing across the plans as well, the Medi-Cal managed care plans. And you guys are very fortunate to have LA Care here and also HealthNet, because LA Care was the first one to get those free nicotine patches, I think 10 years ago, Linda Aragon, with the, you know, when she was part of the DPH tobacco program folks, they were some of the first ones to get it through the helpline for Medicaid. So I think that's maybe also why a lot of LA County people kind of expect this now, because it's kind of on and then it's off, on and then it's off. But and they have expressed, how do we get, you know, nicotine patches to these patients? And some of it's the logistical problem of the helpline not seeing what the helpline is doing, because they need to keep track of who's utilizing the medications, and, you know, are they, you know, hitting up their benefit limit? So they have some data needs, and I'm currently in the process of trying to figure out some of this health information exchange stuff where it's supposed to make our life easier. One thing we did do during the UC Quits project was we got the helpline designated as a public health registry, because someone said, well, you know, we're referring to this state entity. Can we use it instead of the immunization registry, because somehow our EMR doesn't talk to the immunization registry. So how do we leverage that and make it more active? And this is something that I think would be a great solution to have covered patches tracked instead of what's going on, I think, with other states where public health is funding nicotine patches or starter kits, right? And we know 2 weeks may not be enough for a lot of folks. It just may get you off that first week of severe withdrawal. So how do we integrate services even more? And then also broader dissemination of eConsult. I think this 3-year project, the priority is LADHS, but we know the community partner clinics also are very important. So we're trying to include them in our ongoing conversations. And then I know the TRDRP Scientific Advisory Board folks wanted us to go outside of LA County and help other folks too. And actually there's one of the rural Medi-Cal managed care plans, partnership health plan, they use eConsult also. So what we do here in LA, can this also help other counties where you can see this density of smoking map, you know, it's pretty dark orange on Northern California. Okay, so to wrap up, because I know that Medi-Cal Incentives to Quit Smoking project was of interest. Have you guys seen this, our postcard materials from before? So I was the statewide outreach lead for it, working with the helpline and working with the Medi-Cal folks in Sacramento. And Cindy Bella here, if you want to wave hi, Cindy. She was part of one of our outreach team to help with this. So you may have seen our postcards, and what this was a CMS, a Medicare Medicaid Services demonstration project to see how can incentives help with short-term behavior change with the Medi-Cal population. So in this case for California, it was utilize evidence-based services with the helpline. So we had a gift card, Ask and Earn a gift card, which we did not promote publicly in the mass media, but it was through health channels, so through your providers, and then also through the health plans. And then also the other incentive that was promoted within the helpline, if someone called, they would also say, would you be interested in free nicotine patches? And the beauty of it's not just being free, because when I first started this, I was like, isn't it a covered benefit? What's the attraction of having free patches if it's already covered? But as all of you know, there's access barriers, and to have the helpline express mail it, kind of like Amazon Prime, straight to your door, you know, we just know that already gets people going, just like the AskAdviseConnect, you know, anything to reduce access barriers is great. So in this project, we showed that we increased calls, and I just want to highlight, though, when we talk about health plans, I mean, providers, we promoted it through providers, so that green bar on the right shows how when the callers called in and the helpline said, well, how did you hear about us? You know, more Medi-Cal folks than non-Medi-Cal folks said they're providers, but also look at the plans. It's not just about coverage. We pushed out a lot of material through the health plans who know who the smokers are, but in this case, it was because we did these huge household mailings during the time of the Medicaid expansion in 2014. So we had a lot of people calling in, where it actually shut down the helpline for a month or two, I remember. So there is a limit to how many people they can service. So I just want to encourage, when we're thinking, you know, Dr. Ben Frank was saying population health, the plans can also be part of that outreach campaign outside of the doctor's office. So how do we all work together and share data when they especially are the ones that cover a lot of the medications? If you want to know more about our mixed project, we just came out with an entire supplement about the project, about the effectiveness of the incentives and helping people quit. There was some modest benefit for combined the patches plus the gift card. If you want to see some of the priority population impact from the outreach, we looked at different subgroups, including pregnant and parenting women. And also how we were doing some of these direct-to-member mailings with some of the Medi-Cal plans. So we have a lot of hopes now that we've got this published. Now we can start talking to the Medi-Cal medical directors about how do we operationalize this and prioritize this now that it's evidence-based, because that was a demonstration grant and it was great while it lasted, but now we want to transition to how do we sustain this and build on what we know incentivizes people utilize services. Just wrapping up about dissemination and what else is going on. And these are your tobacco tax dollars at work. So the California Tobacco Control Program said, well, all these health system changes are going on. How are we going to support all these health systems trying to do a better job with tobacco assessment and counseling quality metrics and finding out all the resources, connecting with the helpline. So our California Quits team, we're the statewide learning collaborative across providers, health plans, and public health partners. And I just want to also share that we've already been sharing the LA County experience. The helpline had a statewide webinar where they featured some of the folks in the first group. So Dr. Paul Gibney represented LA County about the eConsult project, and then Alameda Health System also shared what they were doing, and they had a very innovative model with the medical assistants being the ones not just asking about tobacco status, but being the ones to initiate the referral, and they are getting 200 a month of referrals to the helpline with this team-based model. So to me, even for me, I'm like, okay, today, literally at UC Davis, we're training some of the medical assistants in our cancer center. Let's try this and see if we can do this team-based model. So really, this is what we want to shoot for in the future about population health, is that we get the providers and the health plans and the public health people all working together. I think LA County was much farther ahead, and so it's a real privilege to be on this project, but I think whatever we kind of figure out here, we can share also across the other counties. So feel free to contact us, and Camille, maybe you can wave hi, because she's just come on board as our project manager as well, and would really appreciate it if you can also fill out the evaluation form and give us feedback or just thoughts about eConsult, because you are the front line, and we want to incorporate your perspectives into how we do this project, which is, if I may say, it's just different from a randomized trial. This is an implementation science sort of project where we're looking at what's working, what's not, how do we adapt this, how do we move forward for LA County. Thank you.
Questions? Over here, Carla.
Thank you, Dr. Tong, for the interesting talk. And I just want to know, when the providers ask and refer the patients, do they have anywhere where they select their language so that maybe when they call, they're already prepared? So, like, if someone can speak Spanish, they already have, like, the AT&T interpreter prepared for them? Is there like a selection for that?
Right. I think we did build that into the eConsult interface so that the doc can select the language. So I know for our Epic interface, it's built in as well. So then the helpline gets it, they'll call back in language.
Yeah, and then I have another question. Is there anything similar, and I think for teens, maybe like a helpline for teens? Now that smoking cessation is might be something with e-cigarettes.
And Gary may be even better than me to talk about this, but I know you do have a teen protocol. You guys have protocols for different subgroups, pregnant women, the teens also, and the vaping issue, though, is I think you guys have tested a vaping protocol as well with a couple counselors, is my understanding.
So we do have a protocol for teen smokers, but as you probably know, the teen smoking rate is for combustible cigarettes is common. It's down to very low percentage because the vaping prevalence is skyrocketing.
Now, but you can still talk to a vapor.
Yes. Yes. So although there's not a lot out there yet to show vaping cessation evidence of effective interventions, although we know a lot about behavior change.
Right.
We know a lot about addiction, and a lot of the concepts related to smoking cessation work for vaping cessation. So we do have a kind of a pilot protocol that we're working on with veterans with the counselors, where we're some kind of iterative process to learn more about how to help people more quickly. Although that hasn't been a high It had a high number of people calling to say, I want to quit vaping there. But we're seeing more and more into parents.
Probably, and maybe Cindy can say about this, but the school districts are also funded from Department of Education, and those folks are called the Tobacco Use Prevention Education folks. So they're usually the ones that are on the front line working directly with the team.
Yeah, but I think Gary's correct. There's not right now rush. Kids saying, I want to quit vaping. I think parents saying it. Maybe I'll talk a little bit this afternoon, but there's not much data about how addicting cigarettes are. I mean, some people, you know, they have nicotine, which is clearly addicting, but also the people that the use is very different. I mean, they use them, you know, just very occasionally. They can go for weeks without them. So I think there's some suggestion they're a little less addicting than other forms of tobacco, but I don't think there's much data on that. We're trying to come up with a mouse model of cigarettes.
Wow.
Other questions? Normal, yeah.
Hi, Ron, good. How you doing?
So, and they call them as possible.
From the program officer on the implementation projects you've been doing, just wanted to see if maybe in the future, if folks aren't necessarily ready for the quit line, to call them, if eConsult has the flexibility for other local resources, either behavioral counseling or to talk to a cessation person who can talk about medication. Just, you know, since you have a platform, it'd be nice to grow from that. So, what are your thoughts on that?
Well, first of all, the eConsult system, I think they do have referrals to other community organizations. I'm just not a user. I don't know all of them. But one interesting conversation we were having is if someone did call the quit line, how can they be funneled back to in-person services? And that's a very interesting conversation.
Okay, perfect. It was a great morning. Thanks, everyone. Norma.
Sorry, I know this is waiting. You mentioned that there are CMEs on the website for, is it only CMEs or are there?
CEUs, yes.
CEUs for behavioral health folks and?
Yes, so we'll get that turned back on hopefully in the next few months. We just wanted to see if we can refresh it.
And that's important because this morning, this is a bad time for substance abuse providers to be here. It's the first of the month and billing and things like Medi-Cal billing and stuff. So this is not a good day. And we'll remember that when we're doing the other online meeting today.
Okay, so everybody, the lunch is over that building to the right side, the tech foyer. Students can join Dr. Hickman and Dr. Frank if you want to talk about, you know, sort of opportunities and future careers in smoking cessation, and we'll give it back at 1:10. Thank you so much. Great. Yes, I am recording.
Yeah, he'll put out a message.